Hi, this is Brian Kim. I'm going to share with you my very first Phaco case since the COVID shutdown. My last case was at the end of March, and now this is the beginning of May. So it's been about 6 weeks since I did my last Phaco emulsification. I don't think I've ever taken a break this long from surgery. So the question is, did this break affect my ability to do the surgery? Did it affect my skills, my decision making? And so I hope that I can be able to answer this by showing you this case. So this was a 2 to 3 plus dense lens as well as a medium-sized pupil. I'm going to do my corneal mark to help me center and size my rhexis, using a cotton tip to help me center the eye. I'm trying to use a cotton tip to turn this patient's eye upward. This is the right eye, but the patient was resisting me, so then I asked her to look upward, and she immediately was able to look upward. These patients who have quick darting movements, you always have to worry they might suddenly move the eye uncontrollably. So I use that Q-tip just to give me a little bit of assurance that she's not going to suddenly move. And of course, I'm guiding her as far as what to do with the eye. And so I was able to make my incisions without any problems. Again, I want to make my incision flat to the iris plane so I can get a self-sealing corneal incision. So I'm injecting some intracameral lidocaine to help numb the eye. You can see I'm not really very well centered. So I finally do center the eye. I'm injecting my dispersive viscoelastic to fill the anterior chamber and viscodilate the eye. I'm going to do my triplanar corneal incision. I make a vertical groove, place the blade into the groove deeply, tunnel through the cornea, turn the eye, and then enter, and this is a triplanar corneal incision. I'm using the closed forceps to go into the incision, and then puncture centrally, and then pull down with the forceps. Once I do that, I'm going to grab the right edge of that flap and go around circumferentially. I'm using the corneal marks to help me center and size the rhexis. Again, the corneal mark happens to be similar size and location as this medium-sized pupil. So I'm able to go around every couple of clock hours, grab and re-grab, and I'm able to maintain the size and centration of this rhexis. I've burped the viscoelastic out of the eye, and then we're going to do the capsulorhexis hydrodissection technique. Place the cannula out to the contralateral equator underneath the anterior capsulorhexis edge into the capsulorhexis. Point the tip down, push BSS, and you get a nice fluid wave. You can see it right there. Decompress on the left side, which happens nicely. I'm sweeping and freeing up the anterior capsule on the left side, and then I'm going to turn the lens on the right side, turning the tip downward. You can see the lens spins quite nicely. I'm going to lift the incision and go in with irrigation off to minimize Decimase trauma. Go in with a chopper and then remove the surface epinuclear material. Once I remove the surface epinuclear material, that's a nice guide that I'm going to be able to go underneath the epinuclear ridge with the chopper, go underneath subincisionally, turning the phaco tip vertically, crushing the lens material between the chopper and the phaco tip. That's the double chop. Place the chopper out to the contralateral equator, crushing it centrally towards the phaco tip, and this crushes the right heminucleus in half. This is the cross chop. I'm pulling the first quadrant up with high vacuum out of the bag, and then crushing it with the chopper against the phaco tip. This is a mechanical fracturing technique where I'm crushing the lens piece against the phaco tip and then emulsifying the lens pieces. I'm going to place the chopper out around the second quadrant, pulling it centrally, and then I'm crushing it against the phaco tip once again. I'm pulling up that piece of the second quadrant up with high vacuum and then crushing it, emulsifying it. I'm using the chopper to lift that fragment up and then grabbing it with high vacuum and then crushing it again. Again, this lens is fairly dense, and so you have to be pretty methodical, crushing and using mechanical fracturing forces to minimize your ultrasonic energy use. I turn the lens and crack it a little bit and then pull it up with a little bit of vacuum, and I was able to emulsify the last piece of that second quadrant. I'm rotating the second heminucleus in front of me, place the chopper out to the equator, placing the phaco tip deep in the bag, pulling the chopper towards the center, crushing it against the phaco tip, placing the chopper out to the equator again, crushing it against the phaco tip, again around that third quadrant, pulling a piece of that third quadrant up with the phaco tip using high vacuum, crushing the lens piece between the chopper and the phaco tip, and once the pieces are small enough, emulsifying the lens pieces. I was a little bit more aggressive with my ultrasonic energy use In this case, again, this is my first case in 6 weeks, so I wanted to efficiently emulsify the lens pieces. I placed the chopper around that fourth quadrant, pulling it centrally against the phaco tip, crushing the lens piece in half. So I'm pulling the fourth quadrant up with some vacuum, crushing it between the chopper and the phaco tip, trying to maneuver the pieces around the chopper and phaco tip, and then crushing the lens pieces, using high vacuum to be able to grasp the lens pieces and then emulsify the lens pieces using ultrasonic energy. Once all the lens is removed, I'm removing the epinuclear material, going around making sure that the chopper is deep to the phaco tip to protect the posterior capsule. I go out with the chopper, push BSS with a cannula, pull the phaco tip out, put the INA handpiece in, and this helps maintain chamber stability. I start removing the Cortex subincisionally, get right up on the anterior capsule material, and then peeling it off. And then I'm going around adjacent to this area, peeling off the Cortex again from the anterior side, peeling it from anterior to posterior. Once the Cortex is removed, I switch to the polish mode. Because this is a smaller pupil, I'm polishing fairly blindly, and I like to go to the polish mode because it's a much more gentle way to polish underneath the anterior capsule edge, so I don't cause any traction on the capsule or the zonules. I go port down and I'm polishing the posterior capsular surface. With this polymer tip, it's very safe to polish the posterior capsule. I'm going to use a BSS cannula to pulse in the subincisional space to see if there's any remaining cortical material. Thankfully, it was fairly clean. So I'm now switching to the cohesive viscoelastic cannula, filling the capsular bag as I withdraw the INA handpiece, and then I'm quickly switching to the sweep. I'm going to use a capsule sweep to polish on the left side, and then I'm going to polish on the right side. And once the polish is complete, I'm going to inject my single piece acrylic intraocular lens into the capsular bag. I want to make sure the leading haptic is in the bag. And as the lens unfolds, I'm going to use the INA handpiece to help me unfold the rest of the lens. I go in with irrigation off, and I make sure that the leading haptic is free, as well as the trailing haptic is free of the optic. Once the trailing haptic's in the bag, I go under the lens, rotate it 90 degrees clockwise, and I tilt it. By tilting it, I'm very confident that both haptics are in the bag because the lens is tilted into the capsular fornix. I remove all the viscoelastic from within the bag. I'm trying to tease the lens and rotate it in such a way that the haptics are in the horizontal orientation. Some studies suggest that rotating the haptics in the horizontal position will reduce negative dysphotopsia. I'm not sure if it addresses all dysphotopsias. However, rotating the haptics horizontally is something very easy to do, and there's no harm in doing it. I remove all the viscoelastic in the anterior chamber. I'm using a BSS cannula to flush the angle, and it also helps to maintain the anterior chamber, and I quickly hydrate my incisions. So in answering the question, did 6 weeks of not doing surgery adversely affect my ability to do the surgery? And the answer is no. I was able to jump in, and the muscle memory that I've developed over many years allowed me to do this case fairly easily. I didn't have any particular trouble struggling with any of the steps. This was somewhat of a dense lens and a medium-sized pupil, and so I did have to rely on my typical techniques, double chop, cross chop, mechanical fracturing techniques, pulling the lens pieces out of the bag. The case may have taken a few minutes longer because I was trying to be extra careful. Again, not trying to rush through the cases and try to be as methodical as possible. All the steps went according to plan and fairly smoothly, and this patient has a nice clear cornea, a fairly low CDE, and a nice self-sealing incisions, and a well-centered IOL with a full capsulorhexis overlap. So I hope this was helpful to you, and I thank you for your attention.